In this section, we'll talk about the diagnosis and treatment of shock. So, what is happening in a patient experiencing shock? Typically, this involves hypotension or low blood pressure. In response to this, the body is naturally going to try and do a few things to help keep the blood pressure up. This includes constricting the blood vessels or increasing cardiac output and contractility. If these compensatory responses don't work, though, the tissues do start to get impaired perfusion, and if this isn't corrected in time, it can result in ischemia, cell death, and eventually organ failure. So, in presentation, what do these patients look like? Again, shock is defined as impaired organ perfusion. This typically involves a decrease in blood pressure, and it can be defined in several different ways. Traditionally, it can be a systolic less than 90 millimeters of mercury, or if you have somebody who is hypertensive at baseline, a drop in their systolic of greater than 40 from their baseline is relative hypotension for that patient. Alternatively, you can also use a mean arterial pressure less than 65, typically reflects hypotension. As we mentioned, there's compensatory responses, so you often see the heart rate increase, and also the respiratory rate may go up, again, because the body is trying to increase oxygen supply to the tissues. Your body is always going to try and protect its most important organs like your heart and your brain. So when those compensatory responses aren't enough to keep the tissues perfused, it's going to start sacrificing less key organs like your kidneys, your liver, and your skin. So things that you may initially see are decreased urine output, and that's typically defined as a urine output less than 20 mils per hour. You often see patients who just feel cold and clammy again because you're constricting blood flow to the extremities. And then as it starts to advance, patients may experience altered mental status as well. As the shock progresses, your cells are going to switch to an anaerobic metabolism. This increases lactate levels and can result in a metabolic acidosis, and you may also see decreased venous oxygen saturation. Venous oxygen saturation is the percent of oxygen that's bound to our hemoglobin in the blood and that is then returning to the right side of the heart. So this kind of reflects the amount of oxygen that's left over after the tissues remove what they need. And so we use it to help us recognize when the patient is extracting more oxygen than normal. A reason for this would be, again, the body is trying to increase tissue oxygenation by extracting more oxygen from the blood as it flows through. We'll talk about a couple different types of shock today, but there are several overarching treatment goals that apply to all of them. So for all of the types of shock, you really want to correct the cause of the inadequate tissue perfusion and try to correct it and increase oxygenation to the tissues. The whole point of doing this is to limit end organ damage and, of course, to try to prevent death. So first, what you need to do is identify what type of shock it is, and then based on that, decide whether fluid resuscitation is appropriate and what kind of pressors and inotropes would best help correct the tissue perfusion. Also, for all these patients, you want to provide good supportive care. So if they require help with oxygenation, you may need mechanical ventilation, and just in general, you keep their electrolytes at a normal range, give them prophylaxis for DVT and stress ulcers if indicated, and you may consider support with nutrition such as tube feedings or TPN. So the three types of shock that we'll talk about today are hypovolemic, cardiogenic, and distributive shock, of which septic shock is the most common. As we mentioned, in all of the types of shock, they're characterized by decreased tissue perfusion. You can also try to identify the type of shock based on various hemodynamic parameters like preload, cardiac output, and afterload. Before we start talking about the different treatments for shock, I think it helps to first understand really what are the hemodynamic profiles for each type of shock. How I like to think about it is what's broken or what is the primary problem. For example, in cardiogenic, it's just like the name sounds. There's something wrong with the pump. So typically a decrease in cardiac output is your problem. And then from there you think about what are the compensatory responses. So as we move to talk about treatment later, hopefully it'll make sense that you want to first find treatments that are going to target your primary problem. So just as a little bit of background, where do we get all these numbers? So there are a lot of different ways to do this, and ICU patients, but there are non-invasive measures that we can pretty much do in anybody. And this is going to give you the basics like temperature, vital signs like your blood pressure, your heart rate, your respiratory rate. You can also use a pulse oximeter to measure things like your arterial oxygen saturation, or even do some studies like echocardiograms to measure your ejection fraction. More invasive things that you may see in the unit, something called an arterial pressure line, or an A line for short. This is a type of line you can see in the picture below, but it basically uses a pressure transducer, and it allows you to monitor blood pressure second to second, so you can really see how the blood pressure is changing with your therapies. There are also several more invasive lines, things like central venous catheters or pulmonary artery catheter is the one that's pictured on the right, where these are big lines that you can thread in through the heart, and they can give you a lot of information. So we'll talk about as far as hemodynamics, you can get a lot of extra hemodynamic numbers. There are also ports where you can draw blood from and give medication. So while they're very useful lines, in general, we try to avoid them. So while these lines are very useful, the first thought is, why wouldn't I put this in anybody? It would be great to have all this extra access and get all this hemodynamic information. Studies have been done on patients who have gotten pulmonary artery catheters and actually found that they have an increased risk of mortality. This may be related to the fact that we often put these lines in patients who are sicker and may be more likely to die, but this data has kind of cut back our initial approach from putting these lines in everyone to definitely trying to be more selective and only putting it in the patients who need it. The reason being, often from the patient's history and how they present with their symptoms, you can a lot of times extrapolate and figure out what the type of shock is without having to put in one of these big invasive lines. So what are all these hemodynamic numbers? Where do they come from? What do they mean? So this is a picture kind of splitting your heart up into the two sides. The blue side reflects your right side of your heart and circulation, so your venous side. Remember, this is going to be a lower pressure side. The right section in red is going to be the left side of your heart and circulation, so the more oxygenated side, your higher pressure side. So one of the pressures that we can measure from a central venous catheter is something called the central venous pressure, or CVP. Recall again that this side of the heart is the lowest pressure, so the number is low, 2 to 6 millimeters of mercury is normal. And I kind of think of CVP as a rough way of measuring a patient's volume status. So if your CVP is elevated, it typically means you have more fluid on board. If it's very low, it means that you're dry. Swan numbers, these are things that you can get from a pulmonary artery catheter, or we call them swans because the catheters are also called Swan-Ganz catheters. Again, you're not going to have these numbers in everybody, but this is the information that you can pull. So the pulmonary artery catheter you can see is started and it goes through the right atrium, through the right ventricle, and then the tip of the catheter actually rests in the pulmonary artery bed. And there's a little balloon at the end, and when you inflate it, what you can see is that it actually is going to equilibrate the pressures between the place where the balloon is and where the left ventricle is. This is called wedging the balloon. And so what it's measuring now is that the pressure, this is called wedging the balloon. So what it's measuring now is actually the left ventricular end diastolic pressure, which is equivalent to the left ventricular end diastolic volume. And that's essentially your true preload. Again, what is kind of the volume status of the patient? So when you're thinking about assessing fluid status in a patient based on hemodynamics, pulmonary capillary wedge pressure is really your gold standard. But again, because this requires a more invasive type of line, oftentimes we use central venous pressure, or CVP, as a rough way of making the same volume estimation. Other hemodynamic numbers that are helpful is how much blood is the heart pumping out. So that's reflected by your cardiac output, which you can see a normal range is about 4 to 7 liters per minute, or we also looked at the cardiac index. The cardiac index is essentially just your cardiac output divided by body surface area, and you can see normally this is above 2.5. The other measure that's important hemodynamically is something called systemic vascular resistance, or SVR. I think of this as the amount of resistance that the heart is pumping against. So, again, if your SVR is very high, that means your vessels are super clamped down. If your SVR is low, it means they're much more vasodilated. The numbers for all of these parameters you see will vary based on the different references that you may look at, but these are just general ranges. SVO2 is your mixed venous oxygen sat. And as we kind of talked about a little bit earlier, this is a true mixed venous sample that's drawn from the tip of the pulmonary artery catheter. And again, what this reflects is the amount of oxygen that's left over after the tissues have removed what they need. So when your SVO2 is low, it means that your bodies have increased the amount of oxygen that they're extracting. So how are all these hemodynamic numbers related? Remember, we're talking about patients with shock who typically have low blood pressure. So what determines blood pressure? It's your afterload or your systemic vascular resistance. Again, how much resistance does the heart have to pump against? The other factor is your cardiac output. So if either one of these is low, it can make your blood pressure low. Cardiac output is a factor for oxygen delivery to your tissues, as well as how much hemoglobin you have and your arterial oxygen saturation. Cardiac output itself is also defined by several factors: your heart rate, so how fast your heart is beating, and the stroke volume, how much volume in terms of milliliters are being put out with each beat. Stroke volume is then determined by three factors. Afterload, we already talked about, so how much resistance the heart is pumping in. Contractility, just how strong is the heart contracting. And then preload, which is essentially the venous return to the heart. And this is measured by the different pressures that we discussed, like central venous pressures or pulmonary capillary wedge pressures. So in the next section, when we talk about the different types of shock and their hemodynamics, we'll go back and think about what, again, is the primary problem or what's broken in each of these types of shock, and that becomes our target. So for example, if your preload is low or your overall volume status is low, this is probably related to a type of hypovolemic shock. If your cardiac output is low, that's a problem with your pump, so that's typically a cardiogenic shock. And then if your afterload or your SVR is low, meaning that you're very vasodilated, this is a key characteristic of a distributive or a septic shock.